Hello, everyone. It's a pleasure to be with you tonight. We are going to cover updates on COVID-19 in transplantation. And I'm Camille Kotton. I'm the Clinical Director of Transplant Infectious Disease, and we had the good fortune tonight of having Emily Bethea with us. She is the Medical Director of Liver Transplantation, Nahil Elias, who's the Surgical Director of Kidney Transplantation and the Quality Improvement Chair, and Gregory Lewis, who is the Medical Director of Heart Transplantation. And it's wonderful to have everybody together. We have certainly worked together a lot during the pandemic as well. So let's start with some information about the state of coronavirus in Massachusetts. I'm sorry for people who are out of the state of Massachusetts, although the numbers throughout New England are pretty similar. But you can see that we still have an ongoing good number of reported cases, over 900 per day in the state of Massachusetts. About 6% of tests done are positive. We have over 650 people hospitalized who are positive for COVID-19, 56 people in intensive care units, and 15 deaths per day in the state of Massachusetts, which is just far too many. And yes, so we still have pretty brisk disease, unfortunately. This is another map, and this comes from the CDC, but this is community transmission by county, and you can see that many areas throughout New England have substantial transmission or high transmission. There are just a few areas with moderate or low. So that means that almost no matter where you live in New England, there is significant, substantial community transmission. And then there's been a lot of interest in wastewater. So this is actually the Massachusetts Water Resources Authority looking at both the North and South Shore over time. And this showed at the beginning of the year, a really high number here was when we had Omicron, and then it fell, and sort of over time it's ebbed and flowed. We currently seem to have a relatively low rate compared to other times. You can see that the numbers went up with the school year in September and October, but now seem to have fallen. This usually is predictive of overall disease rates in the community. So hopefully this portends good things for the future, but nonetheless, there's still enough disease out there that we should still remain quite concerned. But this year, besides COVID, there's actually a little bit more going on, and the CDC and others are talking about the tri-pandemic, so the triple pandemic. And this year, we are actually seeing really high rates of influenza. The CDC has declared that we are at epidemic levels. You can see that on this map, which is quite easy to find. You can just Google CDC influenza map, so it's quite easy to pull up. You can see that the colors in sort of purple is actually a new color this year for very high disease, influenza-like activity. And you can see that much of the South down here is in purple. So high rates of influenza, pretty high rates in orange and red, multiple states, and then sort of that yellow-green in New England, although I would say that Connecticut's in the high range, so it's common. So high rates of influenza this year, unfortunately. And there's also respiratory syncytial virus. So this is a map from the CDC of what happened over the past couple of years since November of 2020 until the end of October. Last year, we saw a definite rise in RSV cases in sort of August and September. And then this year, we have pretty explosive RSV disease. Now, RSV disease, you've probably heard about it in pediatrics, and it's common that it be in pediatrics. But we also see a lot of this in adults, and it actually causes as many hospitalizations and deaths as influenza in any given year in adults, which can be in the hundreds of thousands. So it can cause quite significant disease in adults, and then can be quite significant disease for immunocompromised patients. There's no vaccine for this. So it is something that to prevent, we would want to wear things like masks and avoid sick people and things we've been doing for COVID. But unfortunately, there's actually no There's no major treatment for it. There's no preventative vaccine. So it is something pretty challenging and something that we definitely would all like to avoid. There is an upcoming respiratory syncytial virus vaccine that may be approved in the next few years, but nothing that's right here and now. Now, many of you will have questions about the COVID-19 variants. So over time, we know that viruses mutate, and we've heard about this, and that's what, Delta and Omicron and all of those were. And that's just what we normally see with viruses. Some strains are more resistant to various treatments, and I'll show you more about that. And then, the third one is we don't test individual patients. So if you come in with COVID, we can't actually test you to say like, oh, you have this variant or that variant. We are part of a program where we are doing a huge amount of sequencing, but we don't track it back to the individual patient. So it's more on a public health level, but not that we go back and tell you if, what you had and all those details. Stacy did a very nice job of putting these codes up. So if you have a camera and want to scan that code on the slide, you can go and you can look at the genomic surveillance and what the CDC is doing. It's actually amazing, amazing science and public health measures. Now, and this is pretty sciencey, but I do want to go over what's gone on in recent times. So many of you probably heard that over the summer, it was about early June when we got a lot of BA.5, and you can see this BA.5 here. And so this is August, and the majority of what we were seeing was BA.5. And then we started getting a little more of this BA.4.6, which is just a name of a variant. More of that, and then we started seeing in mid to late October this BQ1 and the BQ1.1, and we're seeing more and more of those. Now, BQ1 and BQ1.1 are actually resistant to the therapeutic antibody that we have given. And for many of you, if you've had COVID, you may have gotten this monoclonal antibody. You may have gone to an infusion center and just gotten a one-time monoclonal antibody infusion. It generally lasts 11 days. Many people have had a great treatment response. Unfortunately, you can see now in the US, almost half of circulating strains are resistant to this. And then for those of you that got Evusheld, which is the monoclonal antibody for prevention, so it kind of acts to protect against infection similar to the way a vaccine works, but a different mechanism. So it's a prevention thing. So for those of you that got Evusheld, over half of the circulating variants as of November 12th in the United States are resistant to Evusheld. So that means the Evusheld isn't going to help protect in over half of the cases. This data on the left are from the United States. Over on the right, this is the New England region. And I just wanted to emphasize that it's actually similar, if not a little more brisk in the New England region compared to all of the United States as far as the emerging variants. And this is honestly the reason that I really wanted to have this webinar to talk with all of you tonight and make sure that you understood what was happening and the importance of vaccination, booster vaccines, and that if you've had Evusheld, it's probably a lot less effective over the next few weeks and months compared to before, because we've actually had a really good run with Evusheld over the better part of the past year. The COVID-19 guidelines were just updated from the National Institutes of Health, and they say they've actually recommended that we have some treatment modification. And they suggest that we move away from using monoclonal antibodies for treatment of active infection and switch to intravenous remdesivir or Paxlovid. Now, unfortunately for transplant recipients, it is very, very hard to safely give Paxlovid because there's a profound drug interaction with tacrolimus, which many transplant patients are taking. It's also hard to give Paxlovid for people on dialysis. For prevention, they are currently saying at this time that because there's no alternative option and because it's quite safe, the panel continues to recommend the use of Evusheld for prevention of COVID-19 in eligible individuals. But that decision should be based on what's going on in the region with respect to resistant subvariants, the individual patient's risk, the available resources, and then logistics. So if it's really hard to get and there's a lot of resistance, it's probably not worth giving. And I think what will happen over the very near future is that likely we will start phasing this out because, as I showed you in that slide, it's not likely to be very effective, unfortunately. And sort of really, unfortunately, at this time, there are no monoclonal antibodies to replace either the treatment monoclonal antibody or the prevention one. So let's double down and think about how we can best protect ourselves. And I think we need to always return to the masking, vaccines, and hand hygiene. You've heard this for the better part of 3 years now. And again, this helps against influenza, COVID-19, respiratory syncytial virus. So as far as the masking and hand hygiene, I do want to emphasize that this is the recommendation for anyone who is immunocompromised. And no matter how many doses of vaccine you've had, since September, if you haven't had the new COVID-19 bivalent mRNA booster, since September, you should have it, unless you had COVID recently. So again, all transplant patients, if you haven't had a booster in September, October, or November, and if you haven't had COVID in the past 3 months, you should get this bivalent booster, unless for some reason you have a medical contraindication. But what I'm seeing is that many transplant patients are coming in with COVID-19 and they haven't had this booster. So then we are missing a really good window of opportunity to get this bivalent booster. And I'm happy to take questions about that. But this new booster, again, you should have the booster in September, October, or November. And if you haven't had it, you should get one unless you've had COVID in the past 3 months, at which point you should get the booster 3 months after having had COVID. Especially because if you recently had COVID, you're probably not well protected against these new variants. Only about 10% of the US population has had the new bivalent booster, which is honestly tragic. You can see in New England, we're probably mostly in that aqua color. So in the 15 to 20% of people have had a booster, but that's still, it honestly should be 100%. There's all these stories about long wait times in the emergency room. You know, people are sometimes trapped there for a couple of days. And honestly, if more people had influenza vaccines and COVID boosters, the wait times in the emergency room might be shorter. It's certainly adding to the burden in our emergency rooms. So we have the holidays coming up, and every year we have seen an increase in COVID after holiday events, and people get together. I have said kind of rule number one about COVID transmission is don't breathe other people's air. And so that means when you're close to people, when they're speaking to you, when you're close enough to be in their air and breathing their air, you're close enough to get COVID-19 from them. So how are we going to do the holidays this year with COVID-19, influenza, and RSV? So this is really a time for higher risk of virus transmission. We would recommend considering smaller gatherings, outdoor gatherings, unfortunately, not these large family gatherings where there's so many people together. And it's honestly probable that somebody in the room has COVID-19, and that's what we see again and again. We do know that masking works quite well. Good KN95, N95, good masking really works. So if you really want to go to a family event, and I fully support that, a good mask, you can wear a mask the whole time. You could eat or drink before or after the event, or I say it's totally fine if you're going to a family event and you want to take food, and when you take off your mask, I would just recommend that you go into a separate room. Maybe you eat and drink in a separate room, you put on your mask again, and you go back and you join the party. And that really should be okay with a well-fitting mask. But unfortunately, what we've seen over time is that our loved ones are often the highest risk exposure. There's been a lot of drama about the going to the grocery store or going here or going there. But you're not really usually not so intimate with people in the grocery store, unless it's a really packed grocery store. But unfortunately, when we're with our loved ones, that's honestly when we've seen the highest rates of transmission. And then I get a lot of questions about travel and when can we travel again? And we have had numerous transplant patients travel. I will say that there's still a good amount of COVID throughout much of the world. You can see the hotspots, the darker, the red or deep red, crimson, the higher the rates of disease. Some places in the world we don't have good reporting from, but you can see, Australia, much of Europe, there's still parts of South America, still brisk amounts of disease. So it is still there. It is definitely in the islands. There are definitely places that don't do that much testing. You can see the cases per capita, deaths per capita, total cases, deaths. I do think that people can fly on airplanes as long as they wear an N95 the entire time they're on the plane. So I always say, eat and drink a lot before you get on the plane, and you could potentially fly to these places. But things to think about when you're traveling are, what is the best masking? You really want to make sure you're wearing a good KN95, N95 when you're on planes, trains, in the terminals, when you're going into rest areas, etc. Whenever you're maybe breathing other people's air, you want to really mask. Make sure your vaccines are up to date before you travel. You want to make sure you've had your COVID-19 booster, your influenza vaccine, all your vaccines are up to date. A big issue is plan for what you would do if you are sick at a destination. Antibody treatments are really not very available throughout much of the world and not so effective anymore. As I talked about, transplant patients can't really safely get Paxlovid, and I would not recommend Paxlovid in a foreign country where you could have profound drug toxicity from the drug interactions. And intravenous remdesivir is not available at many places throughout the world. So I'm sure many of us have thought about this and done this, but consider changing certain destinations for safer travel. My family, multiple times, we have traveled to closer destinations that we could drive to. We visited the great state of Rhode Island. We drove in the car to visit Virginia. We had wanted to go abroad, but we thought that these were safer choices. And we did some COVID mitigation in that we wear masks in rest areas. We ate outdoors, or ate in our hotel rooms. But unfortunately, that's kind of the state of the art. But you can travel, but you just have to do it thoughtfully and carefully. Okay, let's move into the Q&A part of the program. And I think all of us will be speaking. We had the good fortune of having Dr. Gregory Lewis join us. Yeah, Greg, thanks for being here. And we will we'll all take turns answering questions, and Greg Nahel was called to the operating room, so I think we'll help answer his questions.
Okay.
And so what does it mean to be immunocompromised, and how does immunosuppression manifest? Emily, do you want to take this one?
Sure. Thanks, Camille. And I will relay thanks to the audience for sending in questions beforehand. This one's fun from a few questions that people sent. Maybe I'll read one of them because there are other things behind it, and then try and talk a little bit broadly and answer anything else that comes up. And I know Stacy mentioned, if you do have questions, last time we had one of the sessions, people did put a number of questions and other things in the chat, so please feel free to do that. So one of the questions that sort of came up here along with this slide is, why are my blood cells consistently in the normal range when I'm supposedly immunosuppressed? How is immunosuppression manifested? Is it just lack of rejection of the organ? I really have not been sick with colds or the flu, except maybe once since 2015. And so it's an excellent question. I think broadly, if we think about the role of our immune system, it helps us think about what being immunosuppressed means. And so our immune system has a lot of different functions. One of its jobs is to try and recognize and get rid of things that it determines is foreign. So that can be early cancer cells that your body's trying to identify and get rid of. It can be certain types of infection, viruses, bacteria, etc. And so if you're on medicines that help prevent rejection and in some way, quote, suppress your immune system, it might alter your ability to recognize these things that are potentially foreign. And so we want after transplant to prevent your body from recognizing the organ as foreign, but often as a potential side effect, it may not be able to clear viruses or bacteria or other infections the same way. And so different medicines suppress the immune system in different ways. And based on the organ you receive, you may have a different sort of combination of medicines that are used for immunosuppression. Some of them alter our blood counts, some of them don't. And so you can be on medicines that suppress the immune system, but have a normal white blood count or normal components of your white blood cells, neutrophils and other. And so I think just broadly, that's how we often think about it. But it's an excellent question. And just being a transplant recipient puts you in the immunosuppression bucket if you're on any of the medicines that help prevent rejection. But glad to hear that you haven't been sick since 2015. So you're clearly doing some of the things right. But it still means in some ways that we want to be thoughtful and try and prevent or minimize your risk moving forward. Welcome input from Camille or Greg as well.
Greg, anything you want to add? I think that was very comprehensive.
Yeah, I think first of all, I'd just like to say hello to everyone that's able to join. I'm coming in from the clinic over in Yawkey, where I just finished up, so apologize for being late. I agree with everything that Dr. Bethea just said. I would just say that, you know, we have a diverse group of patients on this call, different organ recipients, and also different durations from transplant. So, you know, we have observed in some of our patients that are very early on post-transplant, you know, certainly in the heart transplant recipients, all of you know, we use very high doses of immunosuppression. And so, you know, there isn't, this isn't like a dichotomous variable where you're either immunocompromised or immunosuppressed or not. There's different levels of it. And so I think in the early days post-transplant where we're using the highest doses of immunosuppression, we have been seeing recently that it's taking longer to clear the COVID PCRs in some of our patients. So for the person who asked the question, it's certainly possible that if you're further out from your transplant, you may have a lower level of immunosuppression because we're giving you less of the transplant medications.
Agreed. Okay, let's go. And the next question is, should Evusheld still be taken every 6 months? And is Evusheld recommended after recovering from COVID-19? I did cover this a bit, and I think we're still recommending it, but it is more than half of the variants now are no longer covered by this, by Evusheld. So we are still recommending it in that it's safe and well tolerated, but probably not so protective. So we'll probably phase it out in the near future. I don't know if either of the two of you have recommendations for what you're telling patients now, because many people, it is recommended every 6 months. So many people may be due for another dose.
I'll say in general, if patients have been receiving it and haven't had side effects and tolerated things well, and there's still a portion of the COVID-19 around that they could be protected from, we have sort of continued, but agree that there's probably going to be a movement away from it. And I think that is one of the questions that came up in the chat, Camille, is, do you anticipate that there will be another, although it might not be called Evusheld, some other monoclonal antibody or something on the protective front that is coming out in the future?
Yeah, we've heard that there may be something, but I don't believe it's close, and that's unfortunate. I think the pharma companies have realized that monoclonal antibodies are a lot of development, and then resistance develops fairly quickly. So I don't think it's that there are going to be a lot of preventative monoclonal antibody options, but we are cautiously optimistic, but I don't have the names or knowledge of anything coming shortly down the pathway. And technically, it would be recommended after recovering from COVID-19 in that it might help prevent different strains than what the person had. So to answer the second question, that would be a yes.
Greg, are you guys still recommending?
Yeah, you know, what we've tried to do, I guess, somewhat in line with my earlier response about these different levels of immunosuppression is, for any of you that may be on the call that have been transplanted recently, we are giving Evusheld prior to discharge from the hospital after the index transplant for the first 6-month period. And then, you know, thereafter, I think the answer to this question is somewhat in evolution, right? Because unfortunately, we're seeing lesser returns with regard to the protective effects of the Evusheld. So I don't see this being our strategy for the foreseeable future in terms of the every 6 months getting the Evusheld. And also, as I think Dr. Kotton has covered this already, even when we did have more alignment with the Evusheld and with the coverage of it certainly is not a measure that's going to completely prevent one from getting COVID.
Agreed. Do you want to talk about Evusheld availability at Mass General?
I can start off. So again, we try to make it available to our patients right after they're transplanted. So prior to going home from the hospital, they're getting it while admitted. That's, you know, probably the easiest way to make sure that patients get their Evusheld. For those that are further out, we've oftentimes had an easier time with them getting it done locally, especially for those coming from out of state. We certainly have administered Evusheld in our clinic setting, though it typically will be an add-on to one's AM visit. And so it can sometimes be logistically challenging with getting off to the cath lab or the echo lab and so forth during the visits. So we have arranged for patients to get the Evusheld during their visits here at MGH, but it isn't something that's done as a routine if patients are able to get it done locally.
I'll relay also in the abdominal clinic on both the liver and kidney side. There's the initial ability, but we moved much more towards working with patients to try and do locally. And I think in the upcoming months, especially with some of the discussion here today and the data on the variants, that we'll probably be trying to focus resources on reaching out to patients and emphasizing the bivalent vaccine and some of the other things that right now have the most efficacy over Evusheld and some of the logistics around doing that. So.
Agreed. So how accessible is remdesivir in the outpatient setting? So as I mentioned, the monoclonal antibody that we were using predominantly for treatment in transplant recipients is no longer effective in about 50% of cases. So we are moving away from using that, which we have decided over the past few weeks. And then we are also in alignment with National Institutes of Health guidelines. So we are moving towards intravenous remdesivir. And unfortunately, it is not very available in the outpatient setting. So we do have some outpatient infusion capacity. My understanding is that MGB is trying to increase the number of chairs in the infusion suite for outpatient remdesivir. But it is tricky because patients need to come back every single day and it's not easy to set up these infusion centers in that they need to be in personal protective gear, and it's quite a big deal to set this up. So basically, outpatient remdesivir is going to be much harder to come by, and that is going to be a problem. This isn't something that would be readily accessible in many like outpatient clinics or things like that. And so we do think that probably more patients will end up getting admitted to hospital, even if they don't actually need to be in the hospital for other reasons other than to get remdesivir. So this is going to be a challenge moving forward. If you have remdesivir in your local community hospital and you want to try to do that, that also seems reasonable, although you would always want to talk to your transplant clinic if you're going to make that decision. And it may be challenging if there's a lot of disease out there and there's a lot of need for remdesivir. Do either of you have comments on that? Okay. How about this question? Are antibody tests now reliable, and how soon after receiving a booster should antibodies be checked? So the answer is no, we are not checking antibodies. It's still not a recommendation from the CDC. We don't have enough robust information to know what a single antibody tests mean, and we are not recommending that this be done at this time. What about convalescent plasma for COVID-19, and is that a good treatment option? So this has been used at certain centers. Convalescent plasma is actually plasma, so part of the blood that's taken from people who had COVID-19 and who are convalescing, who are better. So somebody who's had COVID-19, they take out this plasma from the blood and then they pool it. So it's multiple different sets of plasma. It is a safe blood product. We do use a lot of plasma in modern medicine, but this gives antibodies from multiple different people. And is a way of sort of giving much more dilute than monoclonal antibody, but antibodies against COVID-19. Now, the real concern is, as you saw, we have a lot of new variants, and we think that convalescent plasma from a month or 2 months ago, from people having disease 1 or 2 or 3 or 5 or 10 months ago, is not so likely to be effective with these new variants. Now, that remains to be seen, but convalescent plasma is a blood product, so it's something that we would generally give inpatient. And we have not given much at all at Mass General because so far we haven't needed to give it. And we're just not sure that it would be effective, but it is an interesting treatment option and something that we would consider in the right situation, but it may not be effective. Sorry, that was probably a long-winded way to say we haven't given much at all. We would consider it. It's not a great treatment option. I'm going to call on the two of you. What do you think about this? How do immunosuppressive drugs such as mycophenolate and others impact vaccine response?
I'm happy to take it, and have you also, Greg, either of you also weigh in. So there are different impacts from different immunosuppressants. Some of them may impact your ability to respond in different ways. In some of the studies, for example, antimetabolites like mycophenolate were shown to be more highly associated with more limited, for example, antibody formation. But again, we want to emphasize sort of what Camille said. We don't know how to look at, what does having antibodies mean? There are a number of good studies that have shown that even in the absence of antibodies, getting the vaccine was very important. And so having the vaccine in and of itself is something that provides some of the best protection. So what I will say here is mycophenolate is one of the ones that, has been found in some studies and in some of what we've seen to limit some of the response and also lend to more significant infection. But I think there are a lot of nuances here. And I'm not sure how much in detail to kind of go into more of the discussion. I don't know, Greg or Camille, if you have other thoughts.
I can weigh in. I think it's an excellent question. Obviously all of us as transplant providers would love it if these vaccines induced robust immune responses in all of our post-transplant patients. The reality is that one of the reasons that we go through all of those vaccine checklists before we're doing a transplant is that we know that patients respond better to vaccines prior to getting a transplant when we give them immunosuppression than after getting a transplant. So, on the other hand is obviously mycophenolate plays a very important role in keeping our patients healthy after a heart transplant. So we do see attenuated responsiveness to vaccines on the multiple immunosuppressants, including the mycophenolate that patients are taking. But we need to use these immunosuppressants, and we know that that's not a reason to avoid vaccination, because as Emily said, some protection is better than none.
I definitely agree with what both of you said, and definitely the concept that some protection is better than none, for sure. I did see a recent trial where they actually held some of the immune suppression around the time of vaccination. And what was interesting is it looks as though they had a better immune response for a short period of time, but by 3 months later, the vaccine response was the same, whether or not they held the immune suppression. And I was sort of comforted to see this data in that we have thought, should we be holding some of the immune suppression? But that's a real risk in transplant recipients. They could have horrible, even life-threatening rejection. So I was happy to see that we don't have support for holding or stopping immune suppression. So I think that that's, we would never want to do that. And I would advise that nobody consider doing that, in that it could be really a very, very dangerous outcome.
One thing I will say about that, Camille, if I can too, sometimes we're weaning immunosuppression, when someone's just about to be off. Sometimes I do then say, if you're just about to come off your CellCept or your mycophenolate or those meds, literally next week, or you're coming off at that appointment, maybe getting it slightly off is something we do consider. But that's it, if it was part of the plan anyway, not changing the plan based on it.
I love that recommendation. That is really thinking hard about immune suppression and response to vaccine. And then that's really good teamwork. So that's an important comment.
And if I could just add, Camille, just based on this kind of descending dose regimen for post-transplant patients, it's all the more reason to keep up with your boosters, because chances are you're going to be getting lesser immunosuppression as you get further out from your transplant. So it's, again, I think an even stronger reason to keep up to date with your boosters.
And I've noticed that Dr. Elias has joined us. Welcome back from the operating room.
Thank you.
Very happy to have you, as always. Okay, so, we have the next slide's just for you. Perfect timing. So I'm a kidney donor and was told that Paxlovid is hard on the kidney. Is Paxlovid not recommended for kidney donors?
So kidney donors do have a slightly decreased renal function, but by definition, a kidney donor is a perfectly healthy individual with excellent kidneys. So they do have a great kidney function at baseline. Now their kidney function does decrease, and Paxlovid is a combination of two drugs. So the drugs dosage is either 300 milligram with 100 milligram or 150 and 100. And the lower dose is what's recommended with the 150 and 100 to patients who have lower kidney function. So if the GFR is below 60, which probably the majority of donors, prior living donors, are around 60 or just below that, which is reasonable to go with the lower dose is what is recommended.
I will say that's absolutely right, and something worthwhile talking to your physician about, and just reminding them that you were a kidney donor if you've already done the donation. And I will say the hard on the kidney is actually, it doesn't cause kidney damage. It's just something that needs to be dosed according to your kidney function. So if I were a kidney donor, I would still take Paxlovid if I needed it. But I would talk to my physician about the fact I had a single kidney and possible drug interactions, which are really, really important. And then this is, I think, Nahil's picture's up there, but I think this is for all of you. How has COVID-19 impacted transplant organ rejection? Nahil, do you want to get us started?
I can get started, yes. So in general, I don't know that we've seen more rejection. We definitely decreased the immunosuppression, as you were talking about when I joined earlier, for patients who have had exposure to COVID-19. Now, the more relevant piece is probably how COVID-19 kept some patients away from coming in and seeing us, and patients away from getting their labs done. And that is the one thing that you want to keep up with your care and make sure that you're followed closely. Decreasing your immunosuppression when you're sick with COVID-19 is very reasonable, and we usually monitor how people do. And I don't know that we've seen more rejection on the liver or kidney side, but I would welcome the rest of the team and what did they say.
Emily, do you have comments on that?
Yeah, I mean, I think I will say off the bat from the vaccine and other standpoints, we're not seeing it. So very pro-vaccine and pro getting those. When it's coming to the actual infection and your immune system's sort of revving up, there are things we're seeing in the pre-transplant and other settings that, can be challenging, for example, in the liver the liver realm, but have not seen direct COVID-19 sort of impact on organ rejection specifically. There are clearly things that happen sometimes when people have severe infection, the need to reduce immunosuppression, other things that can heighten the possibility of rejection that has to do with the balancing of treating the two things that are going on simultaneously.
Yeah, I would echo what Nahel said, that one of the biggest impacts we've seen is just if a patient has a persistent COVID infection, there's a lot of regulations, as many of you know, around procedural areas. So it's been a challenge to actually get the endomyocardial biopsies. One thing that it will probably be welcome news for the patient on the call is it has the pandemic, in and of itself has prompted us to really take a hard look at some emerging assays to try to do things less invasively and to do assays that can look for rejection that are not involving procedures like endomyocardial biopsies. But we have not seen a big surge in patients developing rejection right after having a COVID infection.
Great. And I think the same is true for lung transplant as well, that it hasn't precipitated rejection. It hasn't caused rejection. What are some other recommended vaccinations for transplant patients besides COVID-19 vaccine? Emily?
Sure. So in general, I think this was mentioned before, the goal is to try and optimize vaccinations before transplant. So everything we can get in before transplant is ideal. I'll put a pitch out and plug out for Hep B and other ones that we want patients to be getting. Post-transplant, we're really trying to avoid the live vaccines, and then knowing that a lot of our other vaccines are not going to be as effective. But Shingrix is one of the ones we've been, talking about more now in the post-transplant population, trying to vaccinate against shingles and things that we can consider. Flu, we said we don't have a vaccine for RSV, but again, just a plug about flu being very prevalent right now and trying to optimize or minimize the risk of significant infection on the flu standpoint. Camille, I'll let you pitch in on any of the others. I just saw my picture up here, but please.
Well, I think you got most of them. I would say that all transplant patients should get an influenza vaccine every fall, unless there's like a strict medical contraindication. But for the majority of people, it really is key. Many people say, oh, I don't need that. But I say it's akin to like wearing a seatbelt in the car. And most of us get in and just buckle up. And it should be the same for flu shots every fall, that we get one. Because we don't want to be in the position of, oh, I wish I'd put on my seatbelt. Oh, I wish I'd gotten a flu shot. So I do think it is key for all transplant patients, and especially this year. Honestly, as I mentioned, the emergency rooms across the country are chock-a-block full. So if you can do anything to avoid having to come into the emergency room, if it means a vaccine, I got mine last week. Yeah, my arm hurt for a day. It's fine, Better to get these vaccines than not. So flu first and foremost, and then there's a new pneumonia vaccine called Prevnar 20 that if you haven't had a pneumonia vaccine recently, you might want to talk with your team about that. But otherwise, Emily, I think you got the important ones. It's always worthwhile bringing up vaccines with your team or your primary care provider if you have questions. So another question that was included is, what is cytomegalovirus and how is it treated in transplant patients? And whoever put this question in must have known that this is a virus that's near and dear to my heart, in that it's not my favorite. I don't have favorites. I'm more like the opposite, but I've done a lot of work with CMV over the years. And so we have, CMV is a virus that has infected about half of all Americans. It's similar to the virus that causes mononucleosis. It is something that is uniquely an infection that we mostly see in organ and bone marrow transplant recipients. We have a really good prevention protocol at Mass General. We do state-of-the-art guidelines, management for prevention and then treatment. Unfortunately, we really wish we had a vaccine for CMV, but we do not. It has been something that has been looked for well over 50 years. Moderna has a new CMV vaccine under investigation, an mRNA CMV vaccine. So it's something that we might have a vaccine for in the near future, but it's been something that's been very hard to find a good vaccine for. Nahil, your picture's up there with me. I know they put it's not something a surgeon usually cuts out of anyone, but something that we all are very expert in managing. Do you have further comments?
Yeah, no, I mean, you're the expert on it. The one thing I would add is, and I've heard it from some patients occasionally, that I got my CMV from my donor. And unfortunately, about half the population are exposed to CMV. So they do have what we say the serology or the antibodies positive. And if the donor or the recipient has it, there is a risk of developing CMV disease. And as Camille was talking about, the prophylaxis is essential for those. We do not select organs. We don't have that luxury based on CMV. I think people who want a CMV negative, because they're negative, will end up waiting too long, and it's not recommended for them to wait when we have such a good prophylaxis that works really well in most patients, and as long as we're on top of it.
Yes, I definitely agree with you. We can't do the matching because it would take too long for everything to be perfectly matched, and unfortunately that could result in really negative outcomes. So you're definitely right. And about 80% of transplants have a CMV risk. So it's, but we're pretty good at prevention and then treatment. Once treated, can CMV return? The quick answer there is yes, it definitely can come back, but we do a lot of monitoring and prevention, and we do our best to make sure it doesn't return. Usually CMV is just a disease of the first year after, within the first year after transplant. It's not usually something that affects people longer term unless they're being treated for rejection or there are further complications. So fortunately, it's usually just that first year after transplant. Greg, you want to take this one? I'm a heart transplant recipient recently diagnosed with end-stage kidney disease. Does dialysis cause extra stress on my heart? And this would be true for lung transplant and even liver transplant recipients.
Yeah, sure. Thanks for the question. I think that, the simplest path to navigate post-heart transplant would be if all the other organ systems were pristine, because we know that the heart obviously plays a very central role and is influenced by the functionality of all the other organ systems in the body, including the kidney. So the need for dialysis in and of itself, as a reflection of end-stage renal disease, does have impacts on the heart. We can see acceleration of valvular heart disease. We can see acceleration of calcification of the coronary arteries. So the short answer is yes, having a condition that mandates the use of dialysis can have impacts on cardiac function. That being said, the heart has been recently transplanted, so oftentimes the heart is among the healthiest of all the organ systems in that context. And we certainly have had patients that are post-heart transplant that have gone on to dialysis that have continued to have a robust and normal cardiac function while on dialysis. So it's something, I guess, what I would conclude by saying is that we will carefully surveil your heart function, as we do with all of our post-transplant patients. And we are certainly grateful to our renal colleagues for helping you to take care of the end-stage renal disease with the dialysis.
Great. Emily, I am awaiting a liver transplant. What are the newest trends in liver transplantation?
Thanks, Camille. I think this fed somewhat into some of the living donor questions that are coming up. I don't want to focus too much on just liver. I will say that as we've seen for a long time, we are still in desperate need of available organs, which we don't have. And so we wish we're able to move forward with more patients on the wait list. And I think that's feeding into a lot more of the living donor considerations and conversations that we're having. I will say there is a lot more in terms of trends and the indications for liver disease and other things going on, but I'm not sure it's sort of the best space, especially given all the questions up here, to kind of go into in detail. I'm happy to answer any specific questions in the chat that we're trying to get through, but I think the ID focus has been here. So I'll leave it at that for now.
How about this one for Emily and Nahil? I'm awaiting a transplant and have a potential living donor. How can we initiate the potential living donor evaluation process? And I think this means now both kidney, but also liver.
So the best way to start is to reach out to your coordinator. We do have sites online, and we actually gonna have links to them in the next slide. And that's the easiest way to initiate the process. One of the important pieces when we're talking about a living donor is we have to evaluate them very carefully because of the risk associated with the procedure. And when we're talking about a surgical procedure, we always weigh the risk against the benefit. A benefit to living donor is their loved one doing better and getting an organ. They do not have physically a direct benefit from the donation process. Now, the donation evaluation does go through multiple testing, and it reassures the person that they're super healthy or that they have a risk that makes them better off not donating. And that's why we have to go through it. And we, as you see in this diagram, how the patients or the potential donors, they're healthy individuals, they're not really patients. They go through the process of testing and being seen in the clinic, and then being considered and evaluated by the entire team who goes over their records to assure that they're, as I said, healthy enough and they have a very, very low risk from donation. We can never do this procedure with no risk. And unfortunately, that risk we have to be aware of, and we have to make sure that it is an acceptable risk for the donor themselves and for us who are putting them through the risk. So that's the important piece about this. And the codes, the QR codes from the last two slides, you can use to get to our evaluation process websites, and that's where the person who's interested can put in their information, and we will contact them, and they will get to come in and see us, go through the evaluation for both either a living liver donation or a living kidney donation to their loved one. Emily, what did I miss?
No, I think that was spot on. I will just echo what Nahal said in regards to the primary focus of the donor team is to ensure the safety of the donor. You know, so when we're talking about people on the wait list, we're advocating, we're trying to figure out how to get you an organ and how to try and get people better, but it's an entirely separate team that meets anyone who's a potential donor. And so I think feeling that that team only has in sort of that evaluation the interest of the donor in mind, and making sure that proceeding or discussing is what's in their best interest. And so we keep those separate. And I think it's really important that if it is something you'd like to consider, you can have anybody reach out to sort of those contacts. And sometimes it's hard to, not sometimes, it's really a difficult conversation to talk about having someone be a donor. So sometimes it's easier to say or to spread the word by saying, do you mind getting the word out? Or do you mind spreading this to your friends? Or do you mind doing things in that way in regards to just being a donor, to just try and help normalize some of the conversation because it's a difficult space, but we're here to try and help and work it through.
Right. All right, let's move on to, there were a bunch of questions put into the question and answer. And if people have questions, you're welcome to answer these now. One of the first questions is the bivalent vaccine on a 6-month schedule? I got mine in September. Is Moderna the only one? Is there a difference between the different bivalents? So there are two. Pfizer and Moderna both have a bivalent vaccine. And right now, there is not a recommendation for a repeat bivalent. So if you got it in September, you are up to date on your vaccines. I would say sit tight. I don't think there's not going to be a recommendation before the end of the year. There may be a recommendation that I'm on the CDC vaccine panel. And so we may decide to vote for that in the future, maybe in the spring, but right now it's just a one and done vaccine. But I do encourage everybody, unless you had COVID within the past 3 months, but everyone who is a transplant recipient, loved ones who lived with a transplant recipient, everyone around a transplant recipient, people who might donate. Actually, all Americans, it's recommended that you get a COVID booster with the bivalent booster that should be given either this past September, October, or November. Okay, so it needs to be a recent one. Like a lot of people are telling me, oh, they got a booster in April. That doesn't count. It has to be within the past couple of months. And it is recommended for everyone aged 5 and up. And we are seeing a lot of people who are telling me, oh, I wish I'd gotten my booster, which I really hope that we can change that. And that was a big impetus for us to have this call tonight. So what about this? What types of outcomes are you seeing for vaccinated transplant patients who get COVID? Are the rates of hospitalizations and deaths still much higher than the regular population? I will say that overall, people have been doing better. We, I would say Omicron over last winter was pretty bad, but in more recent times, I would say since the spring until now, we've had readily available monoclonal antibody. People tend to be much better vaccinated. We are good at managing the immune suppression, and I think overall outcomes have been better. I must admit, I'm a little concerned that we don't have the monoclonal antibody for effective treatment moving forward. And so I don't think that intravenous remdesivir will be as readily available. So things may be more challenging moving forward. And I'm sorry to report that. I wish I had more positive news, but I do think people should think about that as sort of, as I mentioned, thinking about heading into the holidays and travel and whatnot. Who wants to take another question? Emily, I see you're taking some of the questions.
Sorry, try to type. There was one that came up that I do think is important. We've heard before about reducing or coming off your tacrolimus and considering Paxlovid, that some programs are doing that, and should we be considering it here? I think you can always talk to your provider. I will relay that there are a number of people have talked about the drug-drug interactions, the interactions with Paxlovid, for example, and tacrolimus, and even some of the mTORs like sirolimus is quite profound. And so just to give some examples, we've had some people hold or early on reduce tacrolimus, have 1 dose of Paxlovid and have TAC levels in the 30s or 40s. That's very, dangerously high. And so I think the overall thought was that the risks associated with those high levels, what it can do to kidneys, what it can do to seizure thresholds, was prohibitively risky. And so we've moved away from that overall, although there can be individual provider discussions. And I'm happy for Greg or Naho, Camille to weigh in as well.
No, I totally agree. I second that. And it's a big piece, and it's very important to get your transplant providers involved when you have COVID. I'll take another question here asking about, can COVID vaccine or monoclonal antibodies like Evusheld cause a de novo donor-specific antibodies to emerge or increase post-transplant? We did not see that. I'm not aware that that has been a problem. There was good monitoring of patients as we got the vaccine, and everybody got the vaccine, and we have a lot of patients who got the vaccine and did very well. So we recommend the vaccine, and there is no risk of developing antibodies with the vaccine. Camille, do you agree?
I do agree. They've done a lot of research about this. We have learned so much about vaccines in the past couple of years. We've learned so much more than we had in like decades before about transplant patients and vaccines. There's a good one in the...
Camille, if I could just add a quick comment on the Paxlovid. So we were in a position previously where we had multiple choices on the menu, if you will, in terms of how to take care of our patients when we want, to treat them for their COVID. And so in the heart transplant program, we developed a combination approach for the Paxlovid with how to, change your tacrolimus and account for the effects of the Paxlovid. But because of all the drug-drug interactions, it was much easier to pivot to saying, well, let's have you just go to a local place or come in here for a monoclonal antibody treatment. Or if you're admitted to the hospital, we'll go ahead and give the IV form of remdesivir. But I think now the landscape is shifting where if we don't have effective monoclonal antibodies, we're not seeing the effects of Evusheld, we may need to pivot back to the Paxlovid because of that fact, in which case we'll need to just account for the drug-drug interactions. So I think that we're having to adjust to the times in terms of the medicines that we do and don't promote for use.
And Naha, we'll probably have to chat with Leo some. One of the challenges, at least in the liver space, is sometimes people are just on their TAC. And if it's short course and it's other things, like you could consider it. But I think oftentimes, Greg, you guys have some other things on board for some protection during a period of time versus coming off of everything. And so it'll definitely be some weighing and how do we get the labs? A lot of our patients get labs in a way that we don't get the immunosuppression levels for a few days afterward. They're going locally, to a place and not necessarily here. And all those delays sort of weigh in because it's time sensitive. But agree, if we're left with nothing else, we may have to reconsider that, but it's not done lightly.
There's another similar question. Since we seem to be running out of viable therapies for transplant recipients, can you comment on the safety/efficacy of molnupiravir for this population? Is there anything else? So molnupiravir is the other oral antiviral, and we have not used it much. I will say it would be sort of the last choice, and that's both what we have decided at Mass General and then in the National Institutes of Health guidelines, that if we really can't get any other therapy, we would use molnupiravir. Fortunately, it does not have the drug interactions. The initial trials showed that it really was nowhere near as effective as Paxlovid. Subsequent trials have showed it's somewhat more effective. They have not done good studies in transplant recipients, but I would say if we can't get intravenous remdesivir, and if we're so worried about Paxlovid and safety, it would be another option. There's a good question about if people test for COVID the morning of Thanksgiving, can we, if they do a rapid antigen and it's negative, is it safe to have dinner with them? And I would say partially safe to have dinner with them. One big thing we see is that the testing is not great, especially if people don't have symptoms. It's only about like 50% accurate. And then they may be incubating virus such that they could be infectious to you, but they may be testing negative. So I would not rely entirely on rapid diagnostic tests. I have actually seen plenty of transmissions in the setting of everybody tested negative. So I don't actually strongly recommend that as a strategy. If you are going to have dinner with them either way, I would say better that than nothing. But I also would like to consider my recommendation of sitting with them for dinner, wearing your mask, getting a plate of food, and maybe sitting in another room somewhere where you can eat and drink without your mask on, putting your mask back on, and then going out. And you can be part of the party wearing a mask. I will tell you, this is what the infectious disease people are doing quite regularly, because we can't take the risk of being sick and exposing our patients. So you're not alone. Who else wants to grab a question? What questions look good to you guys?
I was typing in the Hep B one right now. Someone had written about what happens to a transplant patient who does not have Hep B immunity after taking the vaccine. I'm not sure if this is pre or post. If you're pre-transplant, we actually recommend, I guess, two things. One question is which Hep B vaccine you got or you received. There's two that we recommend. Mainly, we want to make sure you're getting the high dose hepatitis B vaccine or Heplisav. Oftentimes when people need vaccines, they sometimes receive something called Twinrix or a combination of the Hep A and B and things that aren't as efficacious. And so we have an algorithm to give one of the two vaccines recommended. And if they don't work after you complete them, to actually pivot and try the other one. And if neither one works, then to say that you aren't mounting immunity or response. Post-transplant, it's unlikely that you'll be mounting a response, but the best protection is actually avoidance of Hep B exposures, which can hopefully also be done. And so I can stick in the chat sort of the doses and those vaccines we have with our little dot phrase, and you can also ask your providers. But if you've recently had the Hep B vaccine, it was just one time, there's still another one we could potentially be trying to give to optimize your immunity prior to transplant.
Greg, Nahel, do you see questions you want to grab?
I'm looking at one from an anonymous attendee here, which is there a difference between a young patient and an older organ recipient when it comes to outcomes with COVID? I'm 28, liver recipient, and 6 years post-transplant. So, I have to say that, like a lot of things about COVID, I found that it's very interesting that we have had some older individuals that have been not that long post-transplant, and sometimes they'll even notify us, a week later, and they'll say, "Oh, I had COVID last week. I had the sniffles for a couple of days." And of course, after us getting over the, "Oh my gosh, I can't believe we didn't hear about this," we obviously are very pleased to hear that they had the sniffles for a couple of days and are completely feeling back to normal. And then we've had some other patients that perhaps we would not have expected them to have the course that they did, and they have a more severe course. So, Dr. Kotton may have further insights into this, but I have to say it's been humbling for us to not really be able to predict what the course is going to be. We certainly have seen overall, I do think it's important to state with, that out of all the abundance of caution that we recommend on this call, but overall, the courses have certainly been more mild in our heart transplant recipients during the last 6 months compared to the early parts of the pandemic. But we don't have a kind of a rule where we say if you're below a certain age or if you're a certain distance out from your transplant, it kind of guarantees that this is going to be a smooth ride, unfortunately.
Yeah, definitely. I definitely agree with that. There are a couple of questions about the bivalent booster. What is the longevity? What strains is it effective in preventing? And the bivalent booster is nice in that it covers the original Omicron, the original strains of COVID-19, but also Omicron. So it's a divided vaccine. It half covers the original strains, half covers Omicron. And there's data coming out pretty much like every day because it's a new vaccine. And so lots of testing underway, and it's looking quite good. And yes. And then the other question is, if you had the bivalent or latest booster in early September, will its effectiveness be materially lower after 3 to 4 months? And the answer to that is probably yes. And then can you get another booster in 3 to 4 months? And the answer there is not yet. And we just don't have that recommendation for you to go and get additional doses of vaccine. I will say, if you got a vaccine in the middle of treatment for rejection, or if you just had your transplant, or if there were concerns that you got a vaccine when you had high doses of immune suppression, you can talk with your team about whether you should have a repeat vaccine, because the CDC guidelines do allow us to repeat vaccines if we think that a vaccine was given during a period of intense suppression of the immune system. So if you can always discuss that with your transplant provider, but in general, we are definitely not recommending that people go beyond the CDC guidelines. I can promise you all that I am a very loud member of the CDC vaccine panel, and I'm always waving the immunocompromised flag, and I am always highlighting, not just during meetings, but behind the scenes almost every day, talking with the CDC about immunocompromised patients and what we need to do to better protect and vaccinate and communicate with transplant and other immunocompromised patients. So there is a lot of thought going through that. We promise that we will message you. We've messaged every time there's a vaccine update, the messaging has come out. Hopefully you're getting that through Gateway. If you have questions, the best place to turn to is always the CDC page, where you can just type CDC immunocompromised vaccines. It comes up real quick, and you could take a look at that or discuss it with any of your providers. There's a question about, after you have COVID-19, do you have immunity from the disease? How long does the immunity last? So we're saying about 3 months. That's probably shorter in transplant patients. And then, as I showed you with the new variants, you're probably not well protected against the modern, against the currently circulating vaccine, the currently circulating COVID-19 strains. So prior disease may not protect you against these current strains. And we definitely are seeing people get reinfected again and again. And it can even be within 3 months, even people who are not immunocompromised. There's a question about dining in. What do you recommend to your patients about dining in? Thoughts about that? I said, don't breathe other people's air.
You can avoid it. You should avoid it. That's probably the big message here.
Yeah. Sometimes for people who are really, really wanting to go out to eat, I say maybe they can go for like, when the restaurant first opens, like so that there's not a lot of other people if they sit far away from it. But all of this is like decreasing risk. It's not zero risk. They could go either late in the night, try to sit away from other people, either early, late, sit away from other people, go during like a, Tuesday, Wednesday when it's not so crowded. Nobody should go out like Friday night. I think Friday night is just high risk, not just for COVID-19, but for influenza, respiratory syncytial virus. And I also think you can do takeout. I'm a big fan of takeout. You can go on a picnic. If it's too cold, you can go on a picnic in your car and go like park near a body of water. I'm full of good ideas. My husband mostly agrees, not always. Other questions? As a question, if I do end up with COVID, should we be using the antigen test to test out of isolation, particularly with our potential for longer duration of illness? So the CDC guidelines are that most immunocompromised patients should be, that they are potentially infectious for 20 days. And we definitely have seen that. I don't really recommend using the rapid antigen tests to test out of isolation, in that you can have false negatives. This is something that I would recommend you talk with your transplant providers about, because I think different cases and different details can change. But I also think that I wouldn't hurry to get out of isolation, in that the reason you're in isolation is so that we decrease this pandemic and spread to others. It's a good question. The rapid diagnostics are good, but they're not brilliant. And especially when the virus has been there for a while, and hopefully the overall amount of virus is going down, but it might not be zero risk. There's a question about sensitization. What do you think about desensitization for other organs, liver, for example, to help the immune system and prevent rejection? What do you think about that? Desensitizing.
When we talk about desensitization, it's in general for patients who have preformed antibodies. It's usually either patients who've had multiple transfusions, or they've had prior transplants, or women who've had multiple pregnancies, especially if there were complicated pregnancies. And desensitization is essentially clearing their antibodies so they decrease their risk of rejection. And that's mostly for kidney. Maybe in the heart world, they do it as well. Greg can comment on that. Desensitization for liver is not done, and it's not a problem. Most patients who do have antibodies against their liver donors, they can, their risk of rejection is fairly small. We can control for it with anti-rejection medication. But for kidney and heart, and this is where we test the patient, and we can do in specific situations desensitization prior to transplant, or wait for another suitable organ where they do not have antibodies against.
Yeah, I completely agree with what Nell just said. There's some of our heart transplant recipients are highly sensitized prior to their transplant, particularly those that may have had multiple previous cardiac surgeries, multiple previous transfusions. And if that's the case, then we'll do two things. One is we'll try to navigate around the called antibodies that they have and do either virtual or a direct cytotoxic cross-match before we accept an organ. But if we have such a high percentage of antibodies that we're concerned that it's going to significantly prolong the period of waiting for a suitable organ, then we will pursue desensitization strategies in conjunction with our renal colleagues with things like plasmapheresis and other medications.
There's a question about what actions should we recommend to immune competent people that live with us to protect us? Do they need to essentially behave as if they were immunosuppressed in terms of vaccinating and boosting? Or do they have flexibility? Will being fully boosted for them reduce the risk of transmission to us? It is more about reducing their own risk of serious illness and death. So we do recommend that all household members of an immunocompromised person be very well vaccinated, that they have flu shots, that they have their COVID boosters. As I mentioned, all Americans should have this bivalent booster. And it does help protect themselves, of course, but also helps protect from bringing disease into the home. We know that vaccinated people are much less likely to get COVID-19, and so there's that. And we do think that vaccinated people have less virus, and so there may be lower rates of transmission. So we do recommend that everybody in the household be well vaccinated with all appropriate vaccines as a way to protect themselves, but also to protect the immunocompromised patient. So we call that cocooning the transplant patient. I don't know if people have questions about that one, but that's an important thing. So especially if there's some people out there, we know that there's a lot of opinions about vaccines. So if your loved one says, what do you want for a holiday gift this year? If they're not vaccinated and you want to spend more time with them, you can say, I'd like you to be vaccinated and protect yourself and help protect me.
Right. Well, thank you everyone so much. We actually are a little bit over. So I did include my email in the chat. So if you guys have any additional questions that you'd like answered, or you'd like me to connect you with members of the team, please shoot me an email and I'll be sure to connect you with the appropriate person. But thank you, Dr. Kotton, Dr. Bethea, and Dr. Elias. And unfortunately, Dr. Lewis had to hop off, but thank you all for joining and providing such a wonderful webinar for everyone. And with that,
thank you, Stacy, for organizing.
Yeah, and thanks to everybody.
Camille, for a great talk.